Greetings, everyone, and welcome to the EKG case for the week of Sunday, October 16th. Today's actually not Sunday, October 16th. Today's actually Tuesday, October 18th. And I'm a couple days late with this. I know all of you have just been waiting these past 48 hours for me to send this out. And so rest assured, you can take a deep breath now that here it is. But I just got back from ASEP. I took a red eye home last night and got in around 9 this morning. And ASEP was a lot of fun. There was a lot of people there. Biggest ASEP ever, I think. 5,900 people is what I heard. And it was in San Francisco. The weather was great. San Francisco is always a great city to have a conference, except when you have to come home on a red eye. And it was great seeing a lot of old friends out there. And hopefully everybody had a great time. And so anyway, welcome back. And we're going to go through a few EKGs that really focus on a very simple pearl to keep in mind for this week. And here's the case we're going to start with. You've got an elderly woman with weakness, nausea, and lightheadedness. Now, I know none of you have ever seen a patient like this, right? But nevertheless, this zebra case that you're looking at, you've got to think about the differential diagnosis here. And elderly, weakness, nausea, lightheaded, the differential diagnosis can easily be narrowed down to only 1 or 2,000 things, right? It could be anything. So I'm being a little sarcastic. It could be just about anything. And so a lot of times what we'll do is we'll shotgun with this, get a CBC and a Chem 100, and no reason why, but we'll send off a PT, PTT, INR, urinalysis, chest x-ray, everything. But let's start with an EKG, since that's what this series is all about. Start with the EKG, forget everything else. Here's your 12-lead EKG. So we'll briefly run through the basics here. The overall rate is, it looks okay. I'm not going to count it out, but it's probably the 50s to 60s or so. We'll say her blood pressure is okay, so we're not going to turn this into an unstable bradycardia type of case. This is sinus, and just for the heck of it, we'll talk about that for a second. Sinus is defined as upright P waves in 1, 2, 3 AVF and inverted P waves in AVR. That's how you know this atrial impulse is coming from the sinus node. If it's coming from the sinus node, you ought to have upright P waves in 1, 2, 3 F and inverted in AVR. If you don't, if you've got inverted P waves in any of these leads, or upright P wave in AVR, then that's called an ectopic atrial rhythm. All right, so anyway, whatever, just some semantics. There's a little bit of high voltage out here. It's kind of non-specific. And what else? There is a lot of T-wave flattening, a little T-wave sagging down here in lead 2, some T-wave flattening in V2, and biphasic T-waves in V3, V4, V5, and some ST segment sagging in V6. Now, most of you are probably thinking about Wellens whenever the term biphasic T waves is heard and referred to in the mid-precordial leads, V2, V3, V4, those type of leads. Everyone's thinking Wellens syndrome. And for those people that don't recall, Wellens syndrome is an electrocardiographic T wave abnormality associated with a critical occlusion in the proximal LAD. So most people might be thinking that this patient has ACS. And clinically, that's a pretty good guess. An elderly woman with weakness, nausea, that can certainly be the anginal equivalent for acute coronary syndrome. She's got 2 major risk factors for atypical presentation. She's elderly and it's a woman. And those are 2 out of the 3 biggest risk factors for atypical presentations for ACS. The other one is diabetes, of course. So it would be completely reasonable to worry about ACS in this case. But I want to focus your attention on these biphasic T waves. This is not actually Wellens syndrome, all right? Let me show you true Wellens syndrome. This EKG was sent to me by a friend in Missouri, Chuck Shepard, who runs a great conference out there, the Tom Steele Memorial Conference. And he's the pre-hospital wizard out there. He runs the aeromedical service in Springfield, Missouri, and a really, really great guy. And he sent this EKG to me. This is true Wellens syndrome. This person had a proximal LAD occlusion, and what you notice about these Wellens waves, as Marriott used to call them, is that the T wave goes up and then down, down, and then up. This is sometimes what I refer to as the reverse Wellens waves. And when you see these reverse Wellens waves, this is actually not ACS. This is actually severe hypokalemia. Severe hypokalemia produces these reverse Wellens waves. That's my term. You're not going to see that published anywhere. Hopefully we'll get this published soon. But this is a very, very specific T-wave abnormality for severe hypo-K. Now, I'm not talking about potassium of 3.5, 3.4, 3.3. We're talking about potassiums in the 1s and low 2s, generally speaking. You see, the T wave sags down in hypokalemia, and then this upward deflection, that's actually a big U wave. That is a big U wave. That is a big U wave. Those are real U waves, not the tiny U waves people make a fuss about. These are real U waves. And then out in the limb leads for some reason don't produce the biphasic pattern so much. Instead, the limb leads just give you T-wave flattening, maybe a little sagging here, but mostly T-wave flattening, or you might just see a really long QT. Back to the true Wellens wave for a second. You notice nice T-wave, normal QT. And again, T-wave goes up and then down with the severe hypokalemia. The T-wave goes down and then up, and in the limb leads T-wave flattening or prolonged QT. I'll show you a few more examples of this. This patient's potassium, as I recall, was about 1.9. This is a fairly pronounced case. T-wave drops down, and then big U-wave jumps up into the sky. Biphasic T-wave pattern, but it's a reverse of Wellens in those mid-precordial leads. And then out here in the limb leads, you just see a long QT. Here's another case. Once again, T-wave goes down, and then you've got a big U-wave jumping north, upward into the sky. So it's a reverse Wellens wave. That's a big U wave right there. That's your U wave. That's your U wave. And out here in the limb leads, you just get a lot of T wave flattening or a really long QT interval. All right. And another case. Once again, this person's potassium, as I recall, was about 2.2, and you see that the T wave goes down and then upwards, and that's the U wave right there. A big, big U wave. And initially, there's sagging of that ST segment or the T wave. And out here in the limb leads, just kind of a long QT interval. And then this is a patient that had digitoxicity associated with hypokalemia. And I'm not going to talk about digitoxicity. I just want to focus your attention on the hypokalemia T waves. Again, a biphasic pattern, but it's a reverse of Wellens with an upward secondary deflection. That's the U wave there. The initial deflection is downwards, then the second deflection is upwards. That's the U wave. That's the U wave up there. And out here in the limb leads, just kind of a T-wave flattening type of pattern and long QT. So, very simple pearl for this week. When you've got a patient, in the right clinical setting, of course, if you've got a patient who comes in with biphasic T-waves in the mid-precordial leads, but it's the mirror image opposite looking T-wave of Wellens, or the reverse Wellens waves, think about severe hypokalemia. And it's a nice pearl to keep in mind because you'll pick up severe hypokalemia an hour before the lab calls with their panic value. And you'll be monitoring those patients very, very closely. You might even consider starting them on some magnesium, which helps stabilize them a little bit in anticipation of the potassium that they're going to need. So that's it for this week's Pearl. I'll talk to you next week. Hope you had a good time at San Francisco at ASEP. If you missed it, next year, October, in Denver for ASEP. So until next week, take care.
Hey folks, Scott Weingart here, and this is, I guess, an MCrit we. This is part one of a video on the micro skills of central line placement. If you've listened to any of the good procedure talks out there, there's a great one I have reposted on EMCrit by Mac Moyetti. What you should be doing with every procedure you do is breaking it down into its component parts and really figuring out the difficult procedural parts, and those are called micro skills, the little pieces we put together to get a whole procedure. And you should practice individually those micro skills until you've mastered them, and then blend all those micro skills together into the complete procedure. And central line placement embraces many of the micro skills that go in with all of the Seldinger techniques for placing catheters and lines and what have you. So it's really imperative that anyone in emergency medicine or critical care learn these skills down to the point where you don't even have to think about them at all, that they are so naturally a part of you that it's the same thing as writing your name on a piece of paper, and that requires a ton of practice. Practice well outside of just the clinical venue of actually using these micro skills for procedures. If that's your only practice, you will suck, or at least in my mind, you will suck at these procedures. What you need to do instead is practice outside of them with task trainers, or as I'll show you in this video, just with a couple of pieces of the equipment. It'll allow you to practice a few thousand times, at which point you may be getting barely acceptable at these micro skills. All right, let's get to it. I'd love to hear what you think. Put it in the comments. Scott Weingart, EMCrit, we, blah, 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 blah. Let's get to it, blah, blah.
So Jeremy and I have been talking about breaking down the micro skills of central line placement. And this is a way to deliberately practice this technique in a way that you're not dealing with a patient, in a way that you can actually get skill mastery by breaking it down to each little piece and getting full expertise at that piece before you embrace the whole and do this on a real patient. So what we're going to talk about today is just a few of the micro skills that go into central line placement, and it's really extrapolatable to Seldinger technique in general. All right, so let's show them what we got here. So this is just a needle from a central line kit, and you don't want to use a dirty one, obviously. And my belief is that pretty much every resident should have one of these somewhere so that they could practice. Now, how they're going to get that, I will leave to you, because I don't want to be responsible for causing a lot of problems in the operations of your ED. But I think every resident should have these to play with. So the first micro skill is learning syringe manipulation in the setting of being able to withdraw the plunger back. Because once you enter through the skin during a central line, you're supposed to be exerting constant negative pressure on the plunger. At the same time, you're able to move in and out, change your direction depending on what the ultrasound is showing you. And you have to be able to do that. So the finger motion is thumb on the plunger, and then I have my index finger and middle finger on the, I should say the index, middle finger on the plunger, and the thumb on the actual extrusion of the syringe itself. There's other ways to do this. This is the way I find to be easiest, but you need to practice and get really good at this. Now, when you don't have it in anything, it's going to be consistently pulling back, which is not what you want. So what's a fun way to try this with is actually you get like an orange or something and just pop it in there and just practice moving in and out while trying to exert negative pressure on the plunger. And you have to be getting to the point where that's not going to occlude your ability to manipulate the needle location. So that's micro skill 1. All right. Micro skill 2, and this is really the important one. And I'm just going to put on this cover because it doesn't affect anything and it'll keep me from sticking myself. But if you don't want to put it on for true realism, that's fine. And this micro skill is you're at the point where you've already entered the skin and you've gotten your first flashback into your hub. Now what you need to do is you need to disconnect the syringe from the needle and put a wire in. And this is the micro skill I think people fail at most. And so what you need to be able to do is stabilize the needle in such a way that there is no movement at all of both the needle tip in the vessel causing vascular trauma or the hub that might push the needle in a little bit further, and now you won't be able to pass a wire or actually pull it out of the vessel itself. So very similar to the bridge you use when playing pool, you want as maximally stable as possible. And when you look at a good pool player, they're always going to have as much of the hand in contact with the felt as possible, because that's going to give them the most stable bridge. And whether they have an open bridge or a closed bridge, you'll always see that their entire hypothenar eminence is touching the table, and that these three fingers are inevitably spread as far as possible to give you a beautiful tripod. And so open bridge, closed bridge. It's the same thing for placing the central line needle stabilization. So you get in there, you get your flash. What you want to do is, again, place your hypothenar eminence on the patient's body. That's the equivalent of the pool table felt. And what that's going to do is a few things. It's give you a stable base. It's also, if the patient moves while you're trying to do this procedure, your hand is now a part of their body, and the hub of the needle will stay in its stable position even as the patient moves back and forth. So hypothenar eminence touching, I spread out these three fingers and I grab the needle between my thumb and my index finger. I'm just going to turn so you can see what I'm doing from another angle. So spread, hypothenar eminence touching the patient, beautiful stable base, thumb and index finger at the hub of the needle. So this is what I have going. Some people will even add the middle finger to the hub. I don't like that as much, but it depends on the size of your hands. But the take-home message is stable base and a tight holding of the hub of this needle. Now, when you do this properly, what you should be able to do is, actually smack your hand, move the table, and the needle hub does not move. That's how you know you've gotten this to the point where the micro skill is complete. Now, the next step is actually disengaging the syringe from the hub of the needle without moving it. That's the next skill. Now you might say, oh, this is easy, and it is, but this is where a lot of the scripts happen, because what happens is inevitably it gets pushed in just a little bit, or it gets pulled out just a little bit, and that's enough to dislodge the location of the needle tip. So you have to be incredibly tight, holding it, ready, and now it's actually a twisting motion. People seem to think that this is the lure lock on these, and you should not be using lure locks in general. You should just have a slip. So it can just be a pull, but I find it's a lot harder to disengage that. So I always just do a little twist. And you should just practice time and time again, a couple hundred, couple thousand times, to the point where you can disengage the hub of a needle without causing any movement to the hub. And when you can do that, then you're ready to move on to the next micro skill. The next micro skill is wire management. Now let's just talk for a second about this. The wire comes in its package with the back portion of it sticking out of a packing area. I don't know if that's showing well. It's right there. And that's designed so that the wire does not move. Its whole purpose is to keep the wire from moving. That's going to be deleterious to you moving the wire. So step one, whenever you get one of these, is to actually pull it so it's disengaged from that little packing area. And then you straighten out the J tip. And I actually like to advance just a little bit of this wire for a reason I'll show you in a second. Now you guys might be used to the ones with the little thumb indentations where you don't have to manipulate the wire as much. Learning that is great if that's going to be your kit for the rest of your life. But if you're ever going to run into a kit like this, and I promise you will, I think it's worth learning it this way, and then you could always adapt to the other one, but not vice versa. So managing this kind of wire where they don't have that little thumb situation, I think is advantageous, because then you can use any kit. So the micro skill is you now practice adding in, disengaging your hub, taking the wire, and the idea behind this is to put the wire in the hub in such a way that your first advance gets you very close to being outside or even outside the tip of that needle. Because once that tip of the wire is in the vessel, you're in good shape. Now the next move is to pull back on the entire apparatus. Then re-grab with your thumb and index finger, and again push forward. Pull back, push forward. If you need to withdraw the wire, which is always fraught with peril, but if you decide it's a good idea, then you'll pull back and then advance the whole apparatus. And there'll be some friction in a real patient, so this will not go back into the patient. And you can just keep doing that until the wire is now back into your initial wire thing. And that's really the hard parts of central line placement. Those are the micro skills worth learning. The rest is just understanding the procedure. Now there's a few bonus micro skills. For instance, if you lose this thing, well, now you're stuck with a J-tip. And you could do the ridiculous manipulations where you try to turn it upside down and, force it in there, and it's annoying. And that's not the way it's done. And I should say, you can use the back portion of the wire. It's not as safe, but it's still not designed to protrude through the vessel. This is acceptable, and sometimes you have to do that. But the J-tip is safer because it's actually a rounded edge hitting the vessel wall. So what do you do in those circumstances? Well, you want to straighten the J-tip. You want to straighten the J-tip. Now, this is kind of tough to learn, and I'm going to try to explain it, but you really have to try it yourself to truly understand. The J-tip is a coil around a central solid core. And what you could do is if you hold the wire steady, you could actually advance the coil while leaving the wire stationary. So the movement is you actually grip the wire portion at your hypothenar eminence with your pinky and ring finger, digits 4 and 5, and you lock it to your hand. So now it's locked to my hand. Now with my thumb and index finger, I advance the coil. And so that's the move. And now this is nice if you lose that blue thing. You have your hub there and you've lost your blue thing. Well, oh, no problem. I got a straight, wire right there that now I could advance. And in some kits, it's actually easier to just take the whole wire out of this holder, especially like when I'm doing femoral A lines. I just want the wire free. I don't want it in anything. It's a manageable length that I could handle it. And sometimes that blue thing gets lost. So learning this micro skill of wire straightening, I think, is very important. All right, anything you want to add, Jeremy? All right, so that's micro skills on central line placement. Scott Weingart, EMCRIP Podcast, and behind the camera, Jeremy Faust of various Twitter exercises. And Jeremy, do you have a blog yet?
Not yet.
All right, and a blog in the future.